Good afternoon. This is Dr. Bill Wyatt, and I'm a general dentist that's done nothing but orthodontics for the last 42 years, and I'm going to try to run through some stuff with you today on temporomandibular joint problems. I'm going to try to cover several patients so you see there's a lot more to it than just thinking about joint problems. It mixes up with everything in the person's life almost, and orthodontics and temporomandibular joint problems just go neck and neck. They can't be divided out in there. So I'm a member of the American Orthodontic Society, and this is an excellent society. I'm board certified in that, and if you're a dentist of any kind and are interested in studying orthodontics or knowing some orthodontics, you should try getting in the American Orthodontic Society. We have a bunch of excellent instructors that can teach you orthodontics, and to me, it's absolutely essential that every dentist know something about orthodontics, whether you want to do it or not, but know what can be done, and that's important. So anyway, I'm going to hush this up and get started on this fine lady that I worked on a good many years ago. And she had a kind of a combination in here. She wanted something done orthodontically with her teeth that bothered the heck out of her, having this big diastema up here in the mouth. She wanted that fixed. She had a joint problem, and she had a very stressful job that just bugged the heck out of her, and it was a mess. So we started trying to correct this. We put her in splints. We found out where we had to locate her jaw and went all through all that, but I could not get it to stop bothering her, to stop hurting her. And she was in reacting with her boss all the time. This is correct, and she told me something about that, and she was very unhappy in her work. And so this was on her all the time, and I could not get the jaw joint to stop hurting her, even though we'd fixed everything that should be wrong, and still she had pain with it. Finally, she got her another job where she was not stressful, was happy working and enjoyed it, and we were able to get rid of the jaw joint problem. But she had the problem, and especially when we tried to close this space. So let me get into the uh, crux of this problem. There's nothing wrong with the facial structure. It looks good as far as vertical height of the face and all this. She's doesn't sleep good. You can see the eyes just kind of show that. Now she's got a pretty good smile there, though. Now she's got this large diastema between her upper front teeth. Everything else looks fine as far as that's concerned. So we want to close this space up here. Now a lot of people think, well, you can just close this together. You can put some on it and squeeze them together. That's a big mistake. If you close this together, you're going to squeeze the lower arch, and you'll put force on it and make it go backwards, or else these teeth will get real sore and you'll hold it back, or these will get sore. They both get sore. There's a lot of problems come up by just trying to close a space in the front of the arch. So anyway, you've got to fix it so the jaw is comfortable and you can close the space and have the teeth fit together where they interdigitate without any interference with the jaw position. That's what's the important thing there. But you can fix everything in your life And if you're in a tremendously stressful situation, something is going to break down in you. Just jot that down. You cannot stand up under it. Now, some people take a lot of stress. They kind of enjoy it. Other people, stress really bugs the heck out of them, and they can't take very much of it. But even if you enjoy stress, and you can still load somebody up to where they would just literally break somewhere. And the jaw joint is a weak spot in many people. So anyway, that's the situation you're dealing with. And the patient needs to tell you about it. They need to talk to you about it. So don't run in there thinking you know exactly what you ought to do every time. Let the patient talk to you and tell you what is really bugging them, what is really wrong, where it really hurts. And then you can, well, we were able to get rid of to take care of the pain in every patient that we worked on just simply by sitting and listening to these people talk to us. So that is a helpful thing to do. So we're going to go ahead and show you what we did here, and you can have to pick out what you do with it. But this gets to be complicated orthodontics. It's not simple stuff that somebody just knows how to put some brackets and bands on and jumps in there and starts on one of these cases. And somebody who thinks that orthodontics has absolutely nothing to do with temporomandibular joint problems is so wrong. So anyway, let's get on down the road with this. When we look at the case, we're just almost in good class 1 all the way around. The molars are a little higher back here. We like to kind of level this out so it would come together properly. Now we've got too much depth of bite. In other words, the lower teeth come up underneath here too far, and that's holding this jaw back some, and that's what makes some of the pain here. Some people can be fitting perfectly in order, and still the jaw may need to come further forward. I've got into some cases like that, and they're difficult to do. So we're going to need to bring our jaw forward a little bit, and yet if we close this gap up here, that would make us squeeze this back further. So you got a little problem there. So we had to reduce the size of the lower anterior teeth to do this, to get it done right. It's an interesting situation here. So anyway, let's go on. Now looking at the other side, it's class 1, 2, and yet she's got TMJ problem. Now you've got some space between all these teeth in here, a little bit there, and we're going to need to close this up as much as we can, you see, in this area. So if you add all this space up down here, it will come to about the size of one of the lower centrals down here. So we thought, well, we can take that lower central out, then we'll be able to close these teeth, but then we have to open the bite because the lower teeth were coming around in here on these upper front teeth, and so you got to bring that down, and these teeth will be closer to edge when you get through. So you know that before you even start the case, regardless of the stressful situation that the lady's in. So you're going to have to sit and talk to her about that and let her talk to you, and you find out what's wrong. All right, so we measured this tooth right here. Well, regardless of what the situation is, you either like to take this one or this one, and the one over on the right was less desirable than the one over here, so we, instead of taking this one, we took the one over in this area right there out. Now we put a bracket on it and we ground it down until we had the space In other words, close the space up on the tooth till it was just big as the bracket, and then we had to take it out and then brought it all the way together like that. And this is a little trick of the trade. You probably can see that pretty simple. Okay, cephalometrically, she looks pretty good. No problem in there. All right. This was 1985 when we did this, and she was in a splint during this time, and we had her wearing a splint during this time. Well, let me go back and show you. We took transcranial x-rays to see where the condyle was. You see, when she relaxed it, when she opened, it went out into this area right there. All right. The Panorex showed the teeth in a good class 1 relationship. You see, the lower molar out in front of the upper molar, right here. That went off good. Now, but we had to close this up, and we took this out and closed this too, and the overjet, or where the teeth came in like this over the other one, the lower teeth were fitting up underneath here, something like that, maybe a little further, and we had to pull this up, and that gave us a little more room because this was at an angle. And so if we had the upper teeth and the lower teeth meeting, something like that, and that's what we ended up having to do. Okay, let's go on and see. So here we are with a little flexible wire in place and everything, line it up, and we got two. When we put this on, see, this is after this had the split in it. It showed we had to be out to here, just edge to edge right here to do this. So now we're going to reduce the size of the lower arch. So we'll take this tooth out and then put it back in and tie it to the arch with the arch wire itself. So here's the way we're fitting, but we had to bring this forward. Now when we put it forward, it put these teeth over here. These teeth were not in contact, and we'd have to leave the space back here, let these teeth come together and have a pad on this part, and then let this erupt together while this would not be together while this was apart. This would come together back here in the back, and you'd be together out here, and now you let this come together. That's the way you get out of the splint into the braces. This is not a good explanation for it, but anyway, we'll try to cover that in another video. It takes the whole thing to talk about that. So we pulled it up there. Now when her jaw was out here, it was not stressful, or at least her jaw was not giving her any trouble, but her stress with her work and everything was still there. So regardless of how we fix this up, the stress in the work was having no effect on the jaw joint itself. Okay, now let's see, we're ready to take the lower tooth out, and then we'll start closing this up right up here. Now you can't close this thing. Don't try to close anything up here unless you've got room down here. Don't ever close space up here where the teeth are touching in this area. That just doesn't do it. It puts force on the jaw going back. It makes these teeth that hit early get sore. The ones on the bottom get sore, and you don't have to do anything but just make these teeth sore if the bite's closed, and you'll hold your jaw back, and you won't hit up there, and you'll pull your jaw back where the condyle is back against this retrodiscal tissue, and they'll have trouble from nothing but a painful tooth keep holding your jaw backwards with a painful tooth. All right, hope you learn that over the period of time. You're not going to run off on a weekend and take a course and learn how to do this, but you have to get started somewhere. Okay, here now we're going to see we've already been in the splint, and these are acrylic pads over these teeth, and we're going to let I don't know how we got it here, but we let the last tooth come together, and then when it gets together and you're hitting out here, then we gradually take this off and these teeth come together. And that's the way we get out of the splint. Anyway, that's not what I want to cover all this. We won't have time in this short video to do that. Now she's not scaling and keeping her teeth clean and good during this time, so they need to do that. Okay, we're going to recommend taking the lower right central out, and we've still got this pad. That's what we came in when we took the splint out. We left the upper deal for hitting out here, and we left this open and we covered this, so the splint's in 3 pieces, 1 upper piece and 2 bonded on lower pieces, and that way you can keep the jaw right where it was in your splint. Okay, now the lower molars had ruptured up there and coming in contact. We want this to come down 2. Now we're coming along okay. That's again biting on that plastic cover over those teeth, and we'll take those teeth out. Now, in order to speed this up some, we put an intruding arch in here. This arch is trying to push these teeth down, see? So it's coiled, it would go up like this, and we're going to try to push these teeth down with it. And we pull it down. I'm sorry, that would go up. We took this, would be down here, you see, and we pull it up there. I better erase that. That looks stupid. It'd be going around like that. When we pull it up there, it tightens this spring, hook it in these teeth up here, and it'll bring all of these teeth down while we're picking this up a little bit in here, and that levels the whole arch out that way. Now, here there's a little better view of that intruding arch or leveling arch that we put in there. We've talked about these a lot. We started doing this 40 some odd years back, and it's very efficient to do that with a couple of arch wires like that. Now you'll see how level it is. Now while we were changing over, we had to put her in a upper ramp, see, that kept her jaw forward, and now you're going to be closing this while she's in this ramp, so we have to go in and trim this ramp off while we bring this together. So that's a lot of problem. Sometimes you bond something on the backs of the teeth so that you can bring a group of them together without trimming it constantly. Every few weeks you got to trim it off. So it's a problem to get through that. Now on the bottom we put this, kept the bracket on this tooth after we extracted it, and we trimmed it down, see, and we got the thing so then that you could hardly hold on to it, and then you could bring these teeth right up against it, and then when you took this out, there was no big gap up here in the front, which women don't like and neither men do either, and then closed all this together, and that let us let the teeth down better together. I hope this doesn't confuse people in doing this, but I can see how it would. So anyway, we're allowing this to erupt back and level this arch out right here. Same thing going back across here. So we've got this and this and this taking the part of the splint. So the splint brought the teeth forward to a certain position. So this ramp right here does that. And these ramps, or these pads we bonded on the teeth, take care of the rest of it. Now they've got to let something come together back here at the back so that you've got contact here and here and here. And then you let these teeth erupt together. Now that's not easy for somebody to just grab a hold of and take. So you have to kind of work into this slowly. So anyway, we continue to close this and hold these teeth right where they are. Let me kind of speed through that. That's mostly just orthodontics. There's no big deal with that part. So we continue with that, and we trim this ramp down and kept closing that up. You'd have to make a new one every so often too to do that. Now we've got it closed down to that point, and we're coming now. We got a little bit of space on the bottom too, so we'll continue to close that. I want to just kind of run through this. And we made her a day retainer and a night retainer also. Anyway, we've closed this pretty much up now at that point. And now we've finished, or we've taken her out of the top and we put her in a retainer with this is probably a day ramp that they wear, and then they'll need to wear a heavier one at night. So now here's a cuspid and a cuspid, and this tooth right here will lay pretty close to the center, and then we can have the teeth meet back here, and your lower jaw can be further forward, and you can close the diastema and it'll close up. And we got to close some space in that too before we finish. Alright, this is an upper retainer, does not have anything crossing over the occlusion, and that's 1987 when we got that in there. Now the midline, really if it's ideal, it'd be right about there somewhere, but that's taking one lower central to do this. Okay, now on the sides, the upper, we've pretty well finished it, and now we had a retainer for her to wear at night, and that held her jaw there. Now if you keep the jaw there for years, the whole condyle fossa mechanism will change, and the people can't even bring their jaw back. But they have to wear these retainers, and especially if they take them out part of the day. And I had this lady wearing this retainer not all the time. She could take it out part of the day at work, and then she'd wear one with a small ramp so it didn't stick down like that, but at night she had to put this one in to keep bringing her jaw back. And she lost this thing. About 5 years went by and she had no problem at all. She lost the retainer that was holding her jaw, and she thought, well, she didn't need it. She came back in to me where the thing started hurting again like the dickens, and I said, man, we had all this trouble and we got you out of pain. Now you've lost the darn thing, you haven't been wearing it. She had moved or something. I said, I'll have to start over again unless you can find that old retainer and put it in. So she went back home, and man, she scoured stuff after they had moved, and she found it. and she put it back in and started wearing it and holding her jaw out there, and the pain went away. And I didn't see her again for a long time, but that's something that is interesting with these cases. Now, there are not any quickie cases that you can do and slap on the back and give them a little suck down retainer and expect it to go. So don't expect that. You got to really work and think for your money when you do these TMJ and orthodontics and stressful situations with the person. And you have to listen to them, let them tell you what's wrong, and they'll usually do pretty well. So here it is. Now here it is in 92. All right, the back's closed a little bit, and this opening has opened a little bit here, but this is 1992, and it's doing good, really. She has no more pain. Her jaw stays up there pretty much now, and so she gets along good. And she did all right till she lost her retainer. Then she came back, and so she'll end up wearing that blooming thing, I think, the rest of her life to keep her from getting in any pain again. But she had to change jobs to get out to where she was not under constant stress. And most people cannot put up with that much stress. Something will break on them. Just remember that. Okay, this is 92. Everything's doing good. Her teeth are holding up good. And here's what we've got on the bottom. See, where we lost one lower anterior tooth to do this. And this is the upper retainer in place. Got a little bit of separation here, a little bit up here, but that's not bad. And if she'll stay with it, this can be that way when she's really old. So, hope you have picked up something from this. It'll help you with your work in orthodontics. If you're going to do comprehensive orthodontics and do everything. Now, personally, I feel like these are the kind of cases that ought to be sent out to orthodontists and let the general dentist and the pediatric dentist do these easy things and let them send the hard stuff to the orthodontist. But I don't think I'll ever get that idea sold to the orthodontist. They don't. It is difficult working on these type cases, and whoever came up with this idea to charge a certain amount for orthodontics, like it's nothing, they're all the same. Some of them are 3 or 4 or 5 times harder and more time consuming and more difficult than others. So there should be a variation in the price of orthodontics, and I hope that gets across. It does to some extent. But this adult orthodontics that come in with periodontal disease, missing teeth, abscess teeth, all kinds of things wrong with the teeth, and expect you to straighten them up for nothing. I mean, just the same as you would a kid coming in there. You take some out, sometimes stick an archware on, they'll get straight without you doing much of anything to them, see. And you can run those through like cattle, but you can't run these through like cattle through a chute. They are difficult cases, and that's what the specialists really ought to be doing. And everybody that does dentistry ought to know what can be done with some of these cases. Now, if you wonder, go look at this video I've got out on closing space in adults. We've had several thousand people look at that. Dentists didn't know, or they don't know. They get out of dental school, they've never done anything like that. The orthodontists never have done anything like that in their orthodontic school. or at least I've never heard of it. Now they'll start doing it now because people know that it can be done, and it's going to be done in the future. So if everybody knows it can be done, then people will learn how to do it. So anyway, I don't want to fuss too much about it, but I'm at the end of my rope, and it won't make a whole lot of difference to me, but I want people to know that this can be done. So I'm going to hush now and hope that we can pass this along, and there'll be many people in many places in the world that will see this and see what they have to do. Okay, I'm going to close out here.